have a terrific group of 7 people here tonight. You have all of their biographical information on this yellow page, and I would encourage you to look at it and familiarize yourself with it. I'm not going to introduce them all individually because there's too much to say about them all. But as I said just a minute ago, to Ramin and Liz and Emily and Charlene and Patrick and Maria and Margaret, that I think of them as as points on a 7-point star, with the center of the star being stories of people who have difficulty accessing health care in Oregon. I think of it that way because this evening is a little bit different than perhaps other panel discussions you've been to, and I want to explain how it's going to work. This, as you know, this is part of Marylhurst's Spring into Action Month, and you may or may not know this particular event is inspired by Tom Rule. Some of you may know him. He was the founder and the chair of Marylhurst's graduate program in education and a leader who was deeply involved in many communities, and he died last summer. And I'm among those in this room who miss him. I met him a year and a half ago, and he asked me to help him organize an evening of discussion that was a little bit different than the traditional panelist, I have knowledge, you need knowledge, as some evenings tend to be. He wanted the audience to be involved and to help create the conversation every step of the way. So he looked at the work of Fred Friendly. Some of you may recognize that name. Fred Friendly was the former president of CBS. He was a close collaborator of Edward R. Murrow. He was a visionary who really understood the power of television and the power of that medium to connect people. With the inspiration of Fred Friendly and the leadership of Tom Rule, we put on a terrific discussion in 2010, about the food system, and that we're going to use the same system for this discussion this evening. This is the idea of how it will work. It depends a lot on you. These guys are all up on stage, but this is where a lot of the thinking and discussing is going to go on. We're all here to talk and learn about access to healthcare, and we're going to do it through narratives by telling stories of people that need healthcare and exploring what happens when that need arises. These stories, I want to stress, are made up. They are hypothetical. They are based on real people, drawn from public sources, but then details have been changed. And there's a couple reasons for that. The most important one truly is to allow us to explore all the corners of healthcare access. And in fact, the stories aren't entirely made up yet. So we're going to start with just a few details of a person, and I'll walk us through that. And then together, the panelists and you in the audience, we're going to construct this narrative, who these people are, what happens to them, how they need the healthcare system. You are welcome to throw in a detail when you want to. What happens if this guy gets hit by a truck? What happens when this kid sits next to somebody who has measles in their first grade classroom? This is a way for you to integrate what you want to know about the healthcare system in a narrative that involves a person, which is what the healthcare system is ultimately all about. The 7 people up here are incredibly knowledgeable about giving healthcare, about the system and how it works. They can answer specific questions about policy, about budget, about therapies as they come up. But this is definitely an evening that we're going to build together. So just as an example, and this will probably be the one we'll start with, but just an example, one of the people that we'll talk about, one of the types of people we'll talk about tonight is a family. It includes a mom and a dad and a kid. And then I'll lay out some details of them. They'll fill out some details, and you can stand up, you can raise your hand, you can jump in anytime, you can change the narrative, you can ask specific questions that you want to know of the panelists. The whole idea that Tom had was that this is an interactive experience, even though we don't have computer buttons and we don't have joysticks to move back and forth, but it's very much an interactive people-to-people experience. And I'll be here circulating around. I'll bring the microphone to you when you want to talk, and that's important because we are taping all of this so other people can access the same kind of experience. So just make yourself known when you want to join in. We started a little bit late, so we may go a little bit past 8, but I'm going to try to keep a tight eye on the clock, and I will reserve the last 15 minutes or so to talk about what you do from now, what you do from here. If you have a desire to improve access to healthcare in Oregon, what can you do? Everyone up here will have some ideas. You may have some ideas. You may have some questions, but we're going to end the evening focused in on that. And there's some snacks over here, some cold drinks and some snacks, and I encourage you to go over there and grab something as you need it. I'd also ask you to turn off your cell phones or anything else that moves at this time, moves or vibrates. You can leave it on vibrate if it's not going to bug anybody, but please turn off the ringers. And do you have any questions before we get started? No. Okay. Then let's introduce to you, first of all of our panelists. I don't know if you can all see, but we have Margaret Ali, Maria Brignola, Patrick Curran, Charlene McGee, Emily Wang, Liz Woolsey-George, and Ramin Yazari. And as I said, their bios are all in the yellow sheet. And the family that we're going to start out talking about tonight, Alexei is the dad. He's white. He's in his mid-20s. He was laid off recently from his job as a painter. His wife is Crystal. She's a Latina. She's also in her 20s. She recently lost her job as data entry clerk. She's back at PCC taking classes again in data entry. And they have a little boy who's 5 years old. His name is Alexei Jr. Alexei Sr. has some bouts of depression. He started experiencing depression when he was in high school, but it's gotten worse since he lost his job. Alexei Jr. has a recurring skin disease. It doesn't seem like anything serious, but every so often his skin gets red and itchy and flaky, and it hasn't seemed to be permanently damaged, but they're just part of their existence. And he's never been to a dentist. And they're staying right now with friends in Hillsborough with another family. I haven't made up what that other family's like. Maybe you can join me in figuring that out. So we're gonna start with that family one evening. Let's say it's a Wednesday evening. Crystal's come home from school from her classes. Alexei Sr. has been home all day watching television. Alexei Jr. has had this skin problem flare up, so he didn't go to school today. In fact, he's been home for a couple of days. Alexei starts crying when his toy truck gets stuck under the couch, and his dad starts to get mad. He shakes him, and Alexei says his throat hurts, and Crystal decides she needs to take him to the hospital because this is the third day he's been complaining about his throat hurting. So I'm going to turn this over to our panelists, and like I said, you guys can jump in anytime and change this narrative. But let's start with our panelists. What does this family do? Who does Crystal call? Where does she go? Well, that's a good question. Where should she go, or where does she go? Let's see. First of all, where does she go? Does she go to you, Dr. Yazari, to the emergency room?
Definitely, sometimes, yeah. I certainly see a lot of people who come to the ER for things where if they had easy access to a established primary care doctor or pediatrician in this case, they would not necessarily have to come to me, but a significant percentage of the patients that we see are like that, throat hurting for 3 days, which is rarely an emergency, but might need treatment, but probably doesn't need to be in an emergency room, but we see that a lot.
So what happens when they show up at the emergency room, this family, the mom, dad, and kid? What happens?
We take care of them. That's the first thing. I think from the way that ERs work now is it is like at Emmanuel where I work, or at the Children's Hospital in this case. You don't check insurance, you don't check primary care doctor, you don't do anything until you take care of the patient. So that's just the choice that those hospitals have made, at least, because it's mandated, by the law that we have to take care of all of these patients. So, and so we don't want to create any sense that we're doing what they used to call a wallet biopsy, where you'd check their insurance and then maybe take care of them or not. So you take care of the patient. That's the most important thing first. But after a while, at first when you work in the ER, you're surprised at perhaps how many people come with non-acute complaints or non-emergent complaints, but then you stop asking you stop being surprised, or at least I have. So you just take care of everybody. And there are a lot of legitimate reasons. I mean, this particular family, if they don't have a pediatrician, then who are they gonna see for the sore throat that could very well need antibiotics? If they don't have somebody established at that point, then it's too late. So the work has to be done before they're sick. Otherwise, they don't have anywhere to go. And in our country, at least, ERs are one of the last safety nets in terms of healthcare.
And when they get, we're going to take a few divergent paths of what might happen, but let's think about, like, Margaret, you want to join in? Do you want to talk about what might happen?
What I would like to offer, that before she even goes to the emergency room, that she first calls. Because many of the emergency rooms have a service where they have a nurse that's able to provide guidance and advice. So they should talk with the advice nurse where she could share the symptoms of Alexi Jr., find out what's going on, and they may actually recommend that they go to an urgent care or an immediate care clinic first, because it's far less costly for them, potentially out of pocket. Particularly now they have no insurance, as I understand, and that would, if they had to pay, and they might also then be able to be plugged in with a primary care physician through the immediate care clinic, as well as with a financial counselor who could help see if they would qualify for some of our coverage, such as the Oregon Health Plan. So that might be some options for them before they even go to the emergency room, which could be far more expensive for them.
Emily Wang, your office deals with access and equity. Do you feel that people know about that option, about a free call to an urgent care nurse instead of going to the emergency services?
Probably not all people, yes, especially I would say newer immigrants and refugees and English language learners. And so I think in a lot of countries, home countries that the immigrants in Oregon come from, they probably have like community health workers or, you know, people within their communities that they know and trust and can, you know, communicate effectively with, who kind of share, you know, how to navigate to get services. And then when they come to America, it's such a complex, verification burdened system, and you know, people, even health professionals, don't always know how to navigate smoothly. So when you have the added language barrier, I think it's really hard to get that information on how to access care.
My daughter has strep throat, and I just called yesterday the advice nurse, but I have insurance, and I knew I was supposed to call the advice nurse. But I have to say, I never knew that if you didn't have insurance, you could just call a hospital and say, help me out, I've got these symptoms. So count me in that pile that didn't. I see a hand over here. Let me bring the microphone to you. Let's see. I think I can come down here. Let me hang on to it because it's real sensitive. But
just a little question. So for the immigrant population, do they see the ER as like you're going to get your best care there, and maybe urgent care or clinics would be less good care? I'm just curious.
What was that last part of your statement?
Urgent care as opposed to ER.
Mm-hmm.
Would they consider the hierarchy of the ER being superior care?
You know, it's really hard to generalize. But did you want to say something? Sure.
I mean, I think it's, I think one, it's hard to generalize. I think oftentimes, so I think when you're dealing with the immigrant and refugee population, there are several factors to consider. I said the one, their immigration status definitely factors in, you know, into how, when, where, at what time people will seek to utilize any of the safety net resources that exist. Depending on your, I think how comfortable you are speaking English, or even your ability to even interpret what you think might be communicated. I think that's another one. I think the experiences of people from your community who have utilized these different health systems at different points. You know, with my experience, I'm like a whole host of different scenarios on where, you know, one person can go to clinic A and they have this experience, and good, bad, or indifferent, whatever that is, it definitely amplifies, right? And if it's a bad experience, guess what? Nobody from that community will ever walk into that clinic again. I think another one, even based on the experience as well, the interaction and the way they feel, their comfort level, just from even the minute they walk and enter a building, how comfortable are they? Did they see signs that they could read? Were people there who were friendly and useful to them? All those resources, all those factors definitely go in, are taken into consideration. And I think also, part of the with the immigrant and refugee community, a lot of people come in from different parts of the world that reside here, and people come with different educational level, different experience, different skill sets, different expertise. And I think oftentimes, the system immediately just assume that, this person cannot speak English. And I'll just even use myself. So I'm originally from Liberia, West Africa, and I remember my family first. So a little bit of Liberia in a quick snap. So Liberia had 14 years of civil war. Now we're 20 years out of it. But Liberia was founded by, so after the American Revolutionary War, when the war ended, the slaves who were freed, Liberia was where they went. So Liberia has a very intimate, probably a very close tie to America. I just got back from Liberia in January. And, but a lot of Americans really don't necessarily know that history. And when we first came, so I came to the end of my 6th grade year, and I remember, interacting with the school systems, getting signed up, and I remember vividly, because we're like, well, all these children need to go to ESL class. My mom's like, what's ESL? They're explaining next to me. She's like, but all my kids speak English well. They're like, oh no, but they all need to go there. And I have an older sister who were a year apart, we're like, we're gonna take these two and put them in this class. And we look at each other like, okay, at least we have each other through this experience. And we walk into the classroom and they hand us a book to read. And I remember we looked at each other like, really? Is this what the American system is gonna be? So, we started reading the book, and they're like, you do know how to speak English. You don't need to be in this class after all. And I think oftentimes, those assumptions really inhibit a person's ability, at that point, as much as my parents were trying to, as empowered as they felt, the system disempowered them. And I think it's really something for us to really be conscious of, not to allow our assumptions to really disempower people, especially when people are trying to empower themselves.
I'm going to get to you in a second. Charlene, you have extensive work with the through Kaiser supporting community health organizations. What if Alexi and Crystal and Alexi Jr. didn't go to the emergency room? They live in Hillsborough with a family, with friends. What are their options for other kinds of care?
So there are a lot of different safety net resources that exist. However, sometimes I feel like I'm like this referral entry point, because I tend to use my Facebook page as this community blast. Now people are like, can you post this on your Facebook? Or people need, I'll use an example. So I actually have a friend she went to cosmetology school, so she didn't have insurance, always sick, didn't really know where to go. A couple of times she ended up at Legacy, the ER, and one day she's like, I need somewhere to go where I can really get care. Come to find out, because she didn't know the resource that was close by, there was a community clinic North by Northeast that was literally 3 miles away from her house. And she's like, what is it? I'm like, well, part of it, we have a lot of different safety net resources that exist, but do people know where they are? I think our society, you just think about how many of us really just go and probe in our neighborhoods and know what's there. When you're low income, you're really trying to survive and think, you're not really saying, well, let me go check out this building. Or, a lot of the safety net clinics are also open a couple of times a week, right? Depending on your work schedule, you may or may not see it, depending on your lifestyle. So I think people miss out on those opportunities. But there's the coalition of community health clinics. There are the federally qualified health centers that a lot of their work is filtered through the Oregon Primary Care Association. But I think you have to know what's available in order for you to know when to access it.
You had a question.
Yeah, I was wondering if there's other options like urgent care and immediate care have the same mandate of caring first and not doing the wallet biopsy.
EMTALA, which is the requirement under the law, which is the Emergency Medical Treatment and Labor Act, is specific to hospital emergency departments and for screening of a patient and stabilization, but that does not apply to clinics. and/or to urgent or ICs or immediate care units.
In all of the massive amounts of healthcare reform proposals that have swept the nation in the last few years, has it ever come up to make urgent care also required to assess and stabilize a patient? Does anyone know?
I think there's always an interest in looking at EMTALA because there's some that believe EMTALA is one of the reasons that healthcare is so expensive. And I think the challenge with EMTALA is that we have an obligation for patients to come into the emergency department and be cared for, but there's no similar obligation for continuing care after they've been stabilized from that admission, which I think is one of the issues societally that's causing part of the healthcare crisis.
And you've got a great story to tell about that I want to reserve for a little bit later
okay.
in the
I can do that.
evening. It's a really good story. I want to go to you, Patrick Curran, with Care Oregon. So let's say we'll go back to Crystal and Alexi, and they're in the emergency room and they've been treated by Dr. Yasmin. And I don't know, what did you give Alexi Jr.? Penicillin?
Definitely.
Probably amoxicillin.
And then what state's that family in when you leave them?
Sorry, what's that?
What state is that family in when you leave them? The child's been stabilized. Have you looked at his skin disease?
I think hopefully they're pleased that they were taken care of. And we've taken care of the throat, problem. They might also ask, while we're here, would you look at the skin, this chronic skin condition, which, typically the ER would, I might say, that's clearly eczema and try this, but you still need to have this followed by a primary care doctor, something like that. But, so I think you do your best to be kind and to offer helpful thoughts, but the setting is limited because I also have ambulances coming in and so forth, so I can't spend the amount of time to sort out diets and medications and other stuff that might contribute to some of the chronic conditions. So.
Do you give them enough penicillin? Where do they get the continued antibiotics? Who pays for that?
Well, so they'll get a prescription. So in Portland, in a lot of places there are $4 prescription plans at pharmacies. So Target and I think Fred Meyer and there are other places. So if someone can afford $4, which most people can afford $4, there's a whole host of antibiotics and other medications that cost $4 for a standard prescription. So you might give them that. If they say that they have absolutely no money and you believe them, then often the hospital will try to comp fill something that's really necessary, like for an infection. But typically people can afford, or you choose an antibiotic that will be effective and inexpensive.
And then they didn't have any insurance coming in. Patrick Kern, are they going to have insurance going out of the hospital?
Well, there is some good news here with this situation. First of all, in Hillsborough, Charlene referred to resources being available. If they know of it, and if they go to the emergency room, they will likely find out about it. There is actually a specific clinic in Hillsborough, and there are many organizations throughout the Tri-County area. But there's one called Virginia Garcia Memorial Health Center, and if you don't know about that organization, you really should find out about them because they're wonderful. And they have a primary care clinic, they have a dental clinic, and they have a pharmacy. And they will see people whether they have insurance or not. Most of the people who go to that clinic either have the Oregon Health Plan or Medicaid or are uninsured. And what will also happen at that clinic, as with other agencies that people have referred to, is it is likely that both Crystal and Alexi Jr. would qualify for Medicaid. So they would be able to get the Oregon Health Plan, but they would have to apply, they would have to go through the whole process, and if anyone's gone through that process, it is arduous. But they could go through that process. In the way the current system works, as many of you know, in the crazy system we have, it is unlikely that Alexi Sr. will able to get health insurance through
Why
state.
is that? They're married. It's both their sons.
It doesn't have to make sense. It's the way
Might be the quote of the evening.
it's the way this baby called Medicaid was born and grew up, and the way it was is that it was intended as a program primarily for low-income children and pregnant moms. And those are the main individuals who are required to be covered under Medicaid, where the federal government pays for it and the state pays for it, and they're obligated to pay for at least certain individuals to do that. Those programs are not obligated to pay for anyone who is low income. And so a common misconception is that if someone is low income, then they qualify for Medicaid. And in fact, many, such as Alexi here, would not. It's unlikely. There are some programs through the state that could, but.
Let me come to you. I'll hold it.
Although I recognize more and more employers are not offering health care as one of their benefits. In fact, it's now barely above 50% on a national basis, according to the Wall Street Journal. But if I heard Emily's point earlier was the father had been employed, would he not be eligible for COBRA, which at least would, I mean, depending where he was working, and being, and I don't know how constrained their finances are because we didn't set up that parameter.
You can set it up.
Let's assume for a moment, I mean, you can go best case, worst case. Let's assume for a moment he does have that option. One wonders if he's, number one, even aware of it, because it goes back to your other point. In order for you to decide to take advantage of an option, you first have to be aware of it. Worst case would be if he came from a position where he wasn't even eligible for COBRA. So then what does the poor guy do?
Do you want me to address that?
I mean, especially if she's not working and she's at the university or college. Some colleges, but I don't know about a community college, often has a healthcare option.
Probably a couple of you can address pieces of that. Go
And
ahead.
so I can start, and I'm certainly not an expert in COBRA, but that's a great point to bring up. The usual issue that comes up with COBRA is not necessarily whether he qualifies or not, but whether he can afford it or not. And in many situations, it's extremely unaffordable. And that's usually what ends up happening. And if that is the case, whether he knows about it or not, or if he doesn't qualify, there are precious few other avenues for him in the current system.
Yeah, I'll hold it.
Okay, I'm going to add to this scenario. Now you're in the emergency room, and Alexi Sr. goes into atrial fib because he's concerned about his son. And so we know that he doesn't have insurance. We know that he's unemployed. And now there's a caseworker that's come to Crystal and said, we can't offer you the best health care today because your husband is uninsured.
I can't under the law.
So what happens next?
So if I understand your scenario, I guess if I may, and or our physician from the emergency department, but under the law, we have an obligation first to screen him and stabilize him. So that most likely if he's in, any type of rapid AFib, he needs to first be stabilized. So they would probably try to do that with medications and or cardiovert him to stabilize him. And then he either has to be discharged, and that's usually what happens on those types of sudden incidents, and or he may be admitted for continuing care and stabilization. And then from there, he would be discharged, but I think that's part of the challenge. Now some, which I'm going to talk about later, some hospitals have a provision for patients to have continuing care during an episode of care, which would be that, but others may not. So that may differ. And I know, Doctor.
Yeah, if he's in the ER, he'll get taken care of. There's no, I mean, that would not happen where you, at least, I mean, can't imagine that would happen in an ER where they would say, we're not taking care of you because you don't have insurance. So I've never seen that happen.
Right.
So, yeah.
And it's a violation of the law, and for larger hospitals, it's $50,000 per incident, and for a smaller hospital under 100 beds, it's $25,000. So hospitals are very attuned to the fact that they have to abide by the regulations of EMTALA. So.
I'm going to change the scenario in a second and bring Alexi Sr.'s depression into play, but let's get your comment first.
Yeah, so my question was, after he leaves the ER and he's been taken care of and he had a big operation and surgery, does he get a $50,000 bill in the mail from the hospital? Or so that's the next issue, I think, along the ladder.
He probably would. And depending on how that would work, he would probably end up not needing to be expected to pay for it. That's changed in different hospitals, and every healthcare provider has different rules around